In this video, we're talking about neurotransmission, and we're in the brain. We start with resting membrane potential. Most textbooks say it's negative 70 millivolts, so that's when a neuron in the brain is not firing. And then most textbooks say when it gets up to negative 55 millivolts, that's the threshold where an all or none phenomenon called an action potential takes place in that neuron. So whether a neuron fires or not depends on its neurotransmitters that are communicating with it. So you may have thousands and thousands of different neurons communicating, converging onto this one neuron. Some of them might be excitatory. The most common excitatory neurotransmitter in the brain is glutamate, or it could be inhibitory. The most common inhibitory neurotransmitter is GABA. It stands for GABA, or gamma aminobutyric acid. So GABA is going to open up chloride channels and make it more negative in the cell, getting it further away from negative 55 millivolts. It could hyperpolarize the cell. Whereas glutamate, it opens up ligand-gated sodium channels and allows some sodium to come in and get it closer to reaching that threshold. So this kind of grades up. It's not just flooding in here. You just have, if you have more GABA or more glutamate, just kind of determines whether this cell fires or not. So these are both ligand-gated ion channels. The ligand for this one is GABA. When it binds to the chloride channel, it opens it. Chloride's more outside the cell, so it's gonna flow inside the cell down its concentration gradient. Same thing with sodium. Sodium's higher extracellularly, so whenever that sodium channel opens, when the ligand binds to it, which is glutamate, sodium will go in. Let's say that we have more sodium coming in than we have chloride coming in, and we actually reach that threshold of negative 55 millivolts. Then this depolarization wave opens up voltage-gated sodium channels. So because the voltage is more positive, these channels open up at negative 55 millivolts, and they all open up at once, and just sodium floods in like crazy, and it'll shoot all the way up to positive 30. It'll propagate that action potential down the axon until it gets to the axon terminal. When it gets to the axon terminal, voltage-gated sodium channels open up, and calcium, which is really high outside the cell, will move inside the cell, bind to the vesicles where the neurotransmitters are waiting to be released, and cause exocytosis of, let's say, glutamate in this case. So this is an excitatory neurotransmitter. And I like to bring in anti-seizure medications here because I feel like it really helps bring home all these different receptors, because it can be confusing. I want to talk about the first line drugs used for epilepsy. So whenever someone is having a seizure, they're either having too much glutamate or not enough GABA. Either way, you have more activity going on in your brain. You can have a focal seizure, and a focal seizure is where just one little area of your brain is hyperactive. So, for example, let's just say a little part of your motor cortex that is your finger on the homunculus is hyperactive. You might just have like a finger twitch, and that'd be it. That'd be a focal seizure. And the first line drug for that is called carbamazepine. And carbamazepine works by blocking voltage-gated sodium channels. So if sodium's trying to rush in and it can't, you don't get an action potential and the activity decreases. That's going to help with that focal seizure. Let's say that you have an absence seizure. This happens a lot with kids where they just kind of check out. They'll maybe be sitting in class and just kind of space out, and they'll have no recollection of spacing out or anything like that. I've heard it called absence or absence seizures. And the first line drug for this is called ethosuximide. And ethosuximide works by blocking the calcium channels. So if calcium never gets into the axon terminal, you never have the release of the excitatory neurotransmitter, and so it'll help with that situation. So let's get on to the generalized seizures. So the big ones, the ones you think about when you think about a seizure. So you have myoclonic, which is where you're conscious, but you just kind of have like some kind of muscle jerk that's more generalized. And you can have the big one, the grand mal seizure, called tonic-clonic, which is the big one where you lose consciousness. Some people froth at the mouth, bite their tongue, everything's kind of moving. You have to worry about them hurting themselves. I've had patients that have dislocated their shoulders and had to have a labral repair because they fell while having a grand mal seizure. So there's two primary drugs used here, or first line drugs. One is called valproate, and it works two different ways. So it has a dual action. One is that like carbamazepine, it blocks the voltage-gated sodium channels where sodium can't come in. And then it has the other action is over here at GABA. So we want to increase GABA if someone has a seizure because we want to have an inhibitory effect, decrease the activity. So this is kind of confusing, but we want more GABA out here in the synapse so that it can bind to more chloride channels and open them. So what valproate, and it's also called valproic acid. So when it's deprotonated, it's called valproate. So it's the same drug. What it does is it blocks GABA transaminase. So when GABA comes out here in the synaptic cleft, like all neurotransmitters, they don't stay out there forever. A lot of them will come back in through channels called reuptake proteins. And so it comes back into the axon terminal. A lot of times it gets broken down. So it can be broken down into a metabolite that is not GABA. But if you block this enzyme, this transaminase, that takes off an amino group to break it down, then you're going to have more GABA be released with each action potential, and that's going to cause more chloride to go into the cell. So that's two different ways. That's why valproate is such a good drug for generalized seizures, is because it has that dual action. There's another drug, and this one works over here, right here at the vesicle. There's a protein in the vesicle called SV2A, and SV stands for synaptic vesicle. And it plays a role in the calcium binding to that vesicle and ultimately releasing the neurotransmitter. So levetiracetam is a drug that blocks this. It's a SV2A blocker, and so it's going to block the interaction of calcium with the vesicle that's needed for it to go through exocytosis, and so you don't have the release of the neurotransmitter, so that's going to help with an overactive neuron. So those are the first line drugs. So let's recap that. For focal seizures, carbamazepine, voltage-gated sodium channels. For absence seizures, that would be ethosuximide. It's a blocker of the voltage-gated calcium channel. And then we have the two generalized seizure drugs for myoclonic and tonic-clonic, the grand mal, and that's valproate and levetiracetam. Valproate has a dual action. It blocks sodium channels here, and it also prevents the breakdown of GABA by blocking this transaminase, this GABA transaminase, allowing more GABA to be released with each action potential. And then levetiracetam is the one that blocks the SV2A protein and prevents that calcium interaction that's needed for the neurotransmitter to be released. Now, those are the primary ones, but just to bring it all home, there's some other drugs that can be used for seizures that aren't as common, that work on some of the other receptors. So for example, ketamine works on the NMDA receptor to block that NMDA receptor and prevent that gradual depolarization from -70 to -55 millivolts. There's felbinate, which works on the other type of glutamate receptor called the AMPA receptor. And it blocks that and prevents some of the sodium from getting in there. So that's those. And then there's some that even block, they're agonists to the GABA A receptor. So when benzodiazepines like Valium and barbiturates like phenobarbital, when they bind to the GABA A receptor, they cause it to open up and allow the chloride ions in. So those can be used as well. So benzodiazepines are used some, but I just wanted to go over the first line drugs with those. So let's recap the whole action potential again. So let's say our neuron is sitting at -70 millivolts, and this is a glutaminergic neuron, so it's going to release glutamate. Whenever you have competition between all these convergent neurons that are communicating with this one neuron. So you have the GABAergic neuron trying to hyperpolarize the cell and allow more chlorine, negative charges in. You have glutamate up here that's trying to open up some ligand-gated sodium channels. So these are both ligand-gated. Ligand-gated here, ligand-gated here. The ligand here is glutamate, the ligand here is GABA. And those just open up channels and allow some in. Doesn't necessarily create an action potential. But if you have more glutamate coming in, more glutamate binding, so let's say you have 700 glutamates communicating and like 500 GABA, and you finally get to that point where 70 makes it up to negative 55, then it goes from these ligand channels to the voltage channels. So once it gets to negative 55, the depolarization is going to happen. I mean, the action potential is going to happen. And these voltage-gated sodium channels are going to blast open and sodium is going to go in due to that voltage change. So it's a voltage-gated sodium channel instead of a ligand-gated sodium channel. It's really important to realize the difference there. And so that'll propagate the action potential down the axon. When it gets down to the terminal, it's going to open up voltage-gated calcium channels. Calcium is going to rush in, interact with the vesicle, and cause that vesicle to merge through exocytosis and release that neurotransmitter glutamate into the synaptic cleft, and then you have an action potential. Thank you.